Welcome to IMJ On-Air from the Pomegranate Studios. The Internal Medicine Journal is the academic flagship of the Royal Australasian College of Physicians. I'm Mick Cavazzini, but in a minute I'll hand you over to the journal's section editor for public health medicine. The article discussed in today's podcast was published online in the June edition of the IMJ and is titled Causes for 30-Day Readmissions and Accuracy of the LACE Index in Regional Victoria, Australia. The LACE Index is a prognostic algorithm for predicting the likelihood that a newly discharged patient will come back into hospital because of complications. Identifying patients who are at risk could allow for better targeted care at the first admission, reducing harm to patients and inefficient use of healthcare resources. Other tools like this do exist, but the LACE is the one which has undergone the broadest validation. Retrospective cohort studies have been conducted in the USA, Canada, Singapore, and the United Kingdom. And there have even been 3 studies of the tool in Australia. However, these were limited to metropolitan settings, and the case mix was also restricted. Today's IMJ paper describes the validation of the LACE index in a regional setting, namely Warrnambool, Victoria. This town of 35,000 marks the end of the Great Ocean Road, about 3 hours west of Melbourne. Only by comparing predictive validity in different settings can you say that an algorithm is not compromised by differences in local practice or patient population. The acronym LACE is a nod to the 4 variables that feed into the algorithm: length of stay, acuity of admission, Charleston Comorbidity Index, and the number of ED admissions in the previous 6 months. Once these inputs are crunched together, a potential score of 19 is generated, and patients were stratified as being at high risk for readmission for any value above 9. A patient with a score of 10 is supposed to have a 10% chance of readmission, and for every 1 point increase above this, the risk increases exponentially. In order to track quality of care and performance of the healthcare service as a whole, it would also be useful to score which readmissions are avoidable, and which are just an unfortunate outcome of the patient's illness. The second part of today's study sought to do just that. Conducting the interview with the authors is Public Health Section Editor, Professor Christian Gericke.
Thanks, Mick. Thanks for inviting me to host this podcast. So my name is Christian Gericke, and I currently work at Calvary in Newcastle as a neurologist, and I'm also Professor of Medicine at the University of Newcastle and Professor of Public Health at the University of Queensland.
And it's your public health hat on rather than your neurology hat in which today's paper is set?
Yes, well, most of my research is actually in health services research and health policy, and so I had a particular interest in this paper because it's exactly where this paper sits, the interface between the clinical world and the public health world. So I would ask Reinhard to introduce himself.
Okay, thanks, Christian. Yes, my name is Reinhard, and I'm a general physician and just recently qualified as a public health specialist and a clinical epidemiologist, working in the southwest of Victoria with James.
Thank you, and thanks for the opportunity to discuss our paper. My name is James Gome. I'm a clinician, first and foremost. I'm an FRACP with recognition in endocrinology, and I work in general and acute care medicine. And I'm coming to you from Warrnambool, which is the land of the Peak Warrung people.
Thanks, James. Maybe we should start talking about your paper. So my first question is, what gave you the idea for this paper in the first place?
So patients who represent back to hospital when they get readmitted stay much longer, they have a lot more complications, and also just the readmissions to hospital is often really expensive to the healthcare system. So I came across this risk score probably about 5 years back. We're actually busy doing a remake of our electronic health system with upgrades. And one of the things that we were thinking about is that we actually want to see if we can incorporate it as part of our discharge summary. So the junior doctors who use it will then actually tick a couple of boxes, and then potentially at the bottom of the summary or as a pop-up box for the junior doctor says, this patient has been assessed as a high-risk patient for a 30-day readmission, given their score And then on a follow-up to that is we could think of doing some sort of trial or implementation trial of saying, well, we've got outpatient clinics. There's a lot of evidence for early follow-up versus what they call standard follow-up. So patients would often, depending on what their problems are, get told on discharge, go see your GP in maybe a month or a couple of weeks, or if there's a problem. And in regional areas, there's often a challenge, limited number of GPs, so they wait 6 to 8 weeks to see a GP. And that's often the time period that they come in, because it's often small unresolved problems or medication side effects. Hopefully that answered your question.
Yes, no, that's very good. And I think it's also useful for clinicians to hear that actually what you developed is something that's useful in the clinical setting and not only in the managerial world when it gets to health data.
We've actually been able to set up basically a new outpatient service that has the capacity now to actually be able to follow up patients within 2 or 3 weeks, and the idea would be, if we identify these high-risk patients, should we see them within 2 weeks or 4 weeks so we could actually compare 2 groups, or even longer? Does it not actually make a difference whether they follow up early or not?
Yeah, thanks, Reinhard. And I wondered, obviously Victoria is a bit different from most states in that you have small regional health services and everyone's using different systems, etc. So it's easier to scale in other states, where bigger areas use the same system. Or in Queensland, the whole public sector. So I wondered what system you're using.
So we use an electronic health system called Gericke, which basically incorporates everything's online, barring maybe a couple of paper-based scripts and things that we do. But again, it's the access to information is probably one of the things that made this project a lot easier. We could essentially just pull the admissions and readmissions that we needed, and all of the ICD-10 codes were already there. The main challenge was just setting up the infrastructure to be able to translate that into the risk stratification tool. The limitations, obviously, if all the information isn't added, then that reduces the sensitivity. But overall, because we've got clinical coders that do that already, it's made I think the data pretty robust. Everything was automated, and a couple of buttons that you pressed on the program, and it turned a whole list of ICD-10 codes into a risk tool number.
Oh, sounds very, very elegant. Thank you. So maybe we should get to the results section of your paper.
So testing the accuracy of the LACE index itself. In this particular study, it sort of had a moderate accuracy. So what we found was an area under the curve of 0.59. 0.5 is sort of no better than chance, or 1 is perfect test. And depending on which resource you use, moderate often goes from 0.58 to 0.62 or a little bit higher. But it didn't fare as well in this particular study. And I think the main reasons, or when we analyzed the data, we had slightly higher numbers of readmissions for the period that we studied, which we suspect may have been influenced by the COVID-19 pandemic, but we didn't explore that too much. But
sorry, Reinhard, sorry to stop you. I think our listeners will be missing some context. Maybe we need to be a bit more explicit. So you've retrospectively looked at the records, separated the high and low risk patients, and then the score, the area under the curve, is those that were identified as high risk actually did come back in as readmitted patients, correct?
Yep, that's correct. So we used what they call a nested case control. So you're actually looking forward, and then the area under the curve is just a statistical test that helps us to say, how accurate is this tool to actually identify those patients, so if they got a score of high risk for readmission, did they actually get readmitted? And again, in this particular study, we just found a moderate predictive ability, which is sort of similar to studies in North America or even in other middle-income countries, that that identifies an area under the curve of between 0.55 up to 0.69.
Obviously, we're not expecting a score of 0.9 and above like we might for a diagnostic biomarker like troponin, but what would a useful number be? What is a good score? I mean, when I was recording an interview with Professor Ian Scott a little while ago about machine learning as applied to prognostic algorithms, the comment came out along the way that a lot of the classic algorithms are pretty crude anyway, and they're more useful to a junior clinician who doesn't have that built-up experience, and a senior clinician might well ignore the algorithm and just use their gestalt, which is the spider senses. So what number would how better validated would you like the LACE to be?
It's not a perfect tool. It predicts most patients, but obviously it does get it wrong a lot of the times as well. As a follow-up to that, they actually developed the LACE Plus index, which has about 7 or 8 other additional factors like age above 65, as well as biological sex, to actually make it more accurate. And again, even with that, the LACE Plus index, the best that they could get was 0.75.
And is that better than clinical intuition?
So yes and no. Obviously, the number is higher, but it's much more complex to the extent that it's not being used. Because you can obviously develop the most complex tools that identifies everything 100% accurately, but they are typically extremely impractical for clinicians to actually use it. So I think, just from what I've read on area under curve, I'd have to go into the research on it. But I think if you have a simple tool with a area under the curve of about 0.65, that would make it practical, implementable, and obviously way better than just your hunch.
Go ahead, James.
Yeah, so with full understanding of Prof. Scott's point of view, he's got years of expertise that many people who have to make these decisions or look after these patients don't have. And not all of us are as strong clinicians, obviously, as he is. So I think they're complementary. Clinical gestalt is essential, but having something that is reproducible and accurate and available for junior staff, and for often junior staff who are still learning their way around clinical medicine, but to be able to do that safely and appropriately is an adjunct, and I think a really important one.
Mm-hmm.
Yeah.
Yes, and maybe something we haven't discussed it, that obviously even clinical experience and intuition, so it not only varies in the time you have spent in there. I just thought of examples of very experienced doctors who always do the same thing without self-reflection, and they might have actually perpetuated their bad practice over 20 years. And how are we going to measure this, if not in some kind of objective, with some objective measurement tool, such as the LACE index or others?
Yes, Christian, that's an excellent point, isn't it? As we get more senior or more experienced, it's very comforting to say, well, I'm senior, I'm right because I say that I am. But in fact, we should be able to do better than that. And I would really encourage any clinicians who are listening to the podcast to be brave enough to measure something. It doesn't matter what that something is, but there's real value for measuring, reflecting, and then refining from that. A worthwhile assessment would be to look to see whether this tool, the LACE tool, could be adopted in other regional centres with a view to seeing how generalisable it is. More useful from that should be whether then, having identified patients who are at high risk of representation, whether we or other health services are able to not just identify, but implement processes and programs that will target appropriate interventions to improve healthcare, reduce readmission, and be cost effective.
Could I ask one more nerdy question about the numbers? Again, the first part of the study, the LACE index based on length of stay, the Charleston Comorbidity Index, ED admissions. Now, I think you mentioned in the results that each of those was statistically different between the low-risk group and the high-risk group. were any of them particularly strong drivers?
So just in the LACE index itself, the Charlson comorbidity index is probably the biggest driver of, validity and accuracy. The higher your Charlson score, the higher your risk, and there's a clear correlation in that. And that's just overall. That's not just in this particular study. Then when they actually the original development of the Charlson score was actually updated, I think about 15 years back, where they actually then included age in the Charlson score. So and that also increases the validity and accuracy of the score. In our particular study, what we found was adding things like age over 65. So once you reach 65 and above, there was a clear exponential increase in your risk of readmission. Also, males were more likely to get readmitted, and that's not only in this particular study. It's been mentioned in quite a lot of other studies for a variety of reasons. And then also a length of stay that's too short. Length of stay shorter than 3 days increases the risk of readmission. So that's that fine balance where you don't want to keep a patient for too long because then they get hospital-acquired complications. But if you discharge them too soon, then they just come back again.
That length of stay thing sort of tells you how it is quite a fuzzy proxy. I mean, if a long stay could be a sicker patient, but a short stay could mean poorer care. But who knows? All these things are filtering in without you knowing how noisy it is. Yeah.
They often, the literature reports that, but the definitions are a bit variable, is that a readmission within 72 hours or 3 days is actually classified as what they call a premature discharge. Mm-hmm. So which means even if you initially did nothing wrong, you probably shouldn't have discharged them. So that speaks to the clinical part of it, because you're going to get it right sometimes, you're going to get it wrong sometimes. You can't always find that balance. But using the LACE index, or just something that gives you a little bit more reassurance of, is this a high-risk patient or not? Is this the right decision? That's often where I think tools like these adds benefit. They should be practical, easily implementable, and that's often where I find these tools are useful.
Yes, maybe we should go back to the second part of your findings. I mean, this is the reason why I chose your paper. I found the key finding really interesting also for practicing physicians, that you found that over 40% of readmissions were in fact avoidable. And this is also the factor that's most important, I think, for policy decision makers. So we can get back to that.
Yep. So looking at the classification tool, and what we did find is that up to 41% of patients that came back potentially have a readmission that may have been avoidable. We are looking at doing a validation study on the specific classification tool, but when we looked at just why they actually came back, what we found is that the commonest reason was often healthcare associated infections, which was we had about a 13.4% number of patients that came back, which is slightly higher than the state average. The state average is about 8%. So actually following the study, I looked at, what kind of infections, typically catheter-associated infections, lung infections, which can't always necessarily be prevented, but we could actually then look at what can we do better. Part of that was also cardiac readmissions, where patients often came back during the second admission with fluid overload. And the first admission, that may not have been the primary reason for admission. So it could be, are we giving a little bit too much fluid in that first admission, and they are doing better, but then with any fluid overload problem, eventually that can catch up with the patient, and that's the reason why they come back. So, that could, for example, be used as more care with, the amount of fluid that gets prescribed in the hospital. What could we do differently if we see a lot of patients coming back for adverse drug reactions because there's challenges with their medication? Should we actually have a dedicated pharmacy clinic to try and avoid that. And then, like I said, maybe I can ask James to jump in there if he wanted to maybe address more the sort of the wider implications.
For the novel classification tool, as you've pointed out, Reinhardt, this is a new tool, and we really need to have it validated in other settings beyond our own. But I think it's a really exciting opportunity to do that. And if we were able to do that, to assess the tool's reliability and effectiveness, then we really could apply that or use that in broader clinical applications beyond general medicine potentially, and certainly beyond our local experience.
Yes, I wondered how much of the tool is generalizable to other specialties. So I guess the more you go into subspecialty work, the less generalizable it is. So I just thought of my own work in neurology. Well, I think it would be very hard to use it, and probably it's not as good. But I can imagine that, for example, for a big general surgery service, it is probably very similar to what you are seeing. What do you think about that?
Yeah, I think you're absolutely right, Christian. So when I developed this classification, it was specifically looking at more general medical patients and surgical patients. Obviously, it does not include children because they've got different disease processes, but something that we could all use. And you're right. I think if you go into subspecialty medicine, they see different diseases, and readmissions would often be for different reasons that might be either the disease or the treatment that's given for that.
Again, just to be explicit, this novel tool was to separate the preventable from the avoidable from non-avoidable admissions.
Yeah, correct.
Which data were going into that algorithm, and how do you confirm whether it's right or not?
Correct. Yeah. So just obviously it wasn't in the specific paper because we were limited a little bit by word count. But so this classification is a combination of international frameworks together with the AIHW, or the Australian hospital group, that basically has developed a list of reasons for readmissions that they use as a classification. And it's a really comprehensive list. I think there's about 20 or 30 different classifications based on ICD-10 coding. But again, this is often done or reported to government after discharge and is used more for statistical analysis and planning of long-term policy. So the idea behind this classification was more, can it be used as a point of care test essentially for clinicians to say, well, I can't wait 6 months for this data to be released to actually do something about it. I have a group of patients who seem to be coming back, and let's classify them. What can we do at our health service level to actually try and identify the patients that's coming back? Why are they coming back, and what can we do about it? Whilst the government focuses obviously on the long-term policy changes that they want to implement.
Mick, as an analogy, we often think about with infections, we have broad advice on what to do for particular infections, and that guides our antibiotic choice and it guides our decision making. But in fact, local data tells us resistances, tells us which organisms are more likely to be present. That's what this allows as well. So another way of explaining what Reinhardt's saying is we've got this larger data set which is reported back to at a state level or at a governmental level. What we want to be able to do is have that available to clinicians at a local level to identify what needs to be targeted for this local cohort rather than across a broader group.
Yep.
No, that's very good. I would have asked you 2 more research questions. So one of them is, did you face any barriers in doing your work?
For me personally, it was just time. Two barriers, probably HREC, the Human Research Ethics Committee. So the college does a good job of teaching us to do a bit of research, but doesn't necessarily provide all the tools, and it would need to be supplemented by either further training or getting a mentor that can help you, because the HREC was particularly challenging, not unreasonable. They had really good comments or reasons why they pushed back, but trying to navigate the HREC takes a lot of skill. So I think that is one of the barriers that we faced. And then that we don't necessarily get dedicated time to do research if you're a clinician. You're employed, you do clinical work, and unless you've got employment as a research clinician, often time is a barrier to doing research. So I think there should be more emphasis at a health service level of actually getting clinicians to do more research as part of not just saying you do it because you like it. I think they should actually have dedicated FTE specifically for research.
Yes, no, I fully agree with you. That's one of the main differences. I worked in major European and UK academic health centers, and that's one of the key differences. So where research and clinical practice were integrated, and teaching as well, were all integrated overseas. Here in Australia, it's running in parallel, and if you want to do research, you have to actually kind of reorganize your own workload around it, and it's not in general supported, even in large tertiary hospitals, what it should be. James, you had a question.
Christian, for me, my comment would be acknowledging your strengths and acknowledging where you need to augment them from other people. And so I think this paper in particular speaks to a clinician-led desire for information to then be able to identify between ourselves what strengths we had, but also what gaps we needed, and having enough networks and enough relationships and developing those strengths to be able to enlist other people with other areas of expertise to make something that we're very proud of, but that either of us individually would not have been able to have achieved. And so I would encourage people listening who think, this will be too hard or that this isn't possible, acknowledging and gaining from others' skills. And that's what physicians are very good at, isn't it? We're very good at working in teams. And so my encouragement would be for clinicians who feel they can't do research, you actually can, and it does get easier as you learn pathways and as you learn the skills and effectively a new language. I would encourage people to do that. It's been very rewarding.
I wasn't expecting the conversation to go in this direction, but it's helpful in the context of CPD. The Medical Council expects clinicians to be auditing their own practice. How do you carve out the time and the permissions to do that efficiently without it being a drag? That's really useful.
I think it's also useful for the advanced trainee research projects that you have to start early to get your approval processes. Otherwise, you run into time difficulties because you have to do that during your training. So my advice is to start early and get help early.
Yeah, I think we've covered it pretty well. That was a very thorough discussion.
Yes, you have enough material?
Yeah,
thank you to Mick, Christian, and James. I think this was a good discussion.
Yeah, thanks, Reinhard. That's excellent. And I really like your approach, how you link kind of your research, like how it translates to the clinic, how it changes your prioritization for outpatient clinics, your approach to service planning, starting a new outpatient clinic, and linking kind of the inpatient world and the outpatient world, which in many hospitals run very much in parallel. So I'm very impressed that you're in a small regional hospital, you're doing this. This is one of the reasons why we have you on the podcast. More people should know about it.
Thanks again to the research authors Reinhard Dreher and James Goem, and to IMJ editor Christian Gericke for giving yet more of his time to this college project. I'm also grateful to all of the reviewers who chime in every month to have a listen to story drafts and provide feedback. You'll find their names in the show credits at racp.edu.au/podcast. There you'll also find the musical composers you've heard, and a link to today's article in the Internal Medicine Journal. Remember that all RACP members have complimentary access to this, along with the Journal of Paediatrics and Child Health and the Occupational Medicine Journal. Just go to racp.edu.au/fellows/resources/journals. and follow the links to log in. Of course, time spent reading journals and listening to these podcasts can count towards CPD for Fellows of the College. For each episode, there's a link that takes you to a pre-filled My CPD page, logging this as a Category 1 educational activity. This podcast was produced on the lands of the Gadigal clan of the Eora Nation. I pay respect to the generous custodians of this country. I'm Mick Kabat-Zini. Thanks for listening.